One of my favorite jobs at any ACC meeting is talking to the Parmley Prize winners, and I have one for you here. The paper is from Jack, and it's back in June 2013, Jack Interventions actually, and it's the paper Impact of Public Reporting and Outlier Status Identification on PCI Case Selection, and it's in Massachusetts in specific. It was published in the June 2013 issue, and it is also a paper that offers CME credit, by the way. I am with the prize winner, James M. McCabe, ND. You were at Harvard when you wrote the paper. You are now an associate professor at the University of Washington. First off, congratulations.
Thank you very much.
This all started life as an abstract, if I remember right, correct?
It did. It started as
one of our meetings, wasn't
it? It was last year's meeting. We presented as an oral abstract at ACC 2013, I guess. Yeah.
Now, what did you do, and what did you find? Because this is an award winner now, but it's a fascinating paper.
Oh, thank you. So Massachusetts is an interesting state to operate as a interventional cardiologist. It's one of the few states in the United States that tracks public reported outcomes of PCI and CABG patients per center, and then actually identifies centers that perform worse than expected statistically, and kind of outs them by saying in very public fashion that they have performed worse than expected. And in Massachusetts, this carries actually quite a bit of cachet and is somewhat controversial. We looked at the impact of that on physician behavior, really. There is a growing body of evidence to suggest that with public reporting may come risk aversion. That is, that operators are more wary of performing PCI or CABG in patients who are the most sick. And that may, in fact, be not in the patient's best interest all the time. So we looked specifically at those hospitals that had been outed as performing worse than expected in Massachusetts over the lifetime of the public reporting process there, and wanted to see how does physician behavior change after that public declaration. And what we found was that the case mix of the patients in the year following, and actually the subsequent years following this kind of public outing, decreased. In other words, the risk profile of their patient mix in aggregate went down, suggesting they had patients who are less sick, less ill. And we did not see a reciprocal increase in other institutions, suggesting they weren't taking these really ill patients who may have appropriately required PCI and they did not send them to other hospitals, so far as we could see. They weren't sending them to bypass surgery, so far as we could see. So there's a couple of steps of assumption here, but I think it's a point of evidence that may suggest ongoing and maybe exacerbated risk aversion in the setting of being kind of publicly outed as a institution that it is not performing statistically as well as the state of Massachusetts would expect.
What can be done about this? I mean, risk aversion is, like you say, it can be good or it can be really harmful for patients.
Yeah, well, I think it's a very controversial topic. On the one camp would say, well, if it's a poor performing hospital, they probably shouldn't be taking care of the most sick patients. I don't think that's not my camp. I think that that outlying institutions tend to be quaternary care centers. They tend to take care of, get sort of the sickest of the sick patients at their hospitals, maybe do larger case volumes, which makes the statistical methods of being declared an outlier more possible. So I personally think that adjusting the public reporting process may be the most beneficial way to sort of stem the tide of risk aversion. And there is actually a number of kind of ongoing processes in that regard. New York State has been kind of the leader in public reporting for many years, and they, since 2006, have stopped considering patients who present with cardiogenic shock in their risk profile assessment at all. So they take them out of the numerator and the denominator and, let people do what they think is best without sort of fear of kind of worsening their numbers, so to speak. Yeah.
Now, this paper, unlike many of the ones where we're talking about papers that are just out, this is a Parmley Prize winner, so it's been out for a few months, about 10 months. In that time, anything happened in Massachusetts? Any reporting? Do you hear from friends and associates who are thinking about changing the laws there? Anything happening?
Well, yeah, I think there's continued to be a growing body of evidence around this. There's kind of a little bit of a momentum swing here, perhaps. There's been a couple of other great papers. My good friend Karen Joint has published a great paper in JAMA a few months ago, also looking at this. And so I do think that there is some momentum around kind of iterating on the public reporting process, making it perhaps more maintaining the sort of strengths of public reporting, but making it a process where interventional cardiologists and the cardiology community in general might buy into the concept a little bit more fervently and feel that they are being sort of treated fairly. And I think that's an important thing. But having buy-in both from the public health community and the cardiovascular community is exceptionally important to make public reporting really work.
Well, Dr. McCabe's paper, as I said, is a CME paper, so please go back to the June 2013 issue of JACC Interventions, read the paper, and see for yourself what we're talking about at CardioSource World News. I'm Executive Editor Rick McGuire.